Okay, so this is a patient. You can see the 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 exterior nose pre and post surgery. There's been some improvement. However, that is the ultimate question. Who determines when surgery is successful? Is it those guys, the surgeons that do it, or the patient that went from this to that? Anyways, oftentimes, surgeons rely, even the patients rely on, patient-reported outcomes, their quality of life after surgery. So based on their survey and conversations, unfortunately, no matter how good of a job the surgeon feels that he does, if the patient comes back and say, I'm still not feeling good, that means the surgery was not good. Even if they go in, look at everything looks good, and patient comes back to say, I'm still not feeling good. So that is just where we are right now. And, in nasal airway obstruction, they normally use the nose scores. Catherine spent some time talking about the nose score, which is, you have 5 questions and you can scale from 0 to 5, multiply by 5 to get your value. So low scores means good. So improvement. High scores mean bad. So given the nasal, the nose score, patient comes in feeling some stuff. How do you feel? Blah blah blah. Have their score. Post, they do the same thing. They have their score. Then the surgeon can decide, okay, there's some improvement or not. How can CFD help? CFD, we've been talking about CFD. We have a lot, we can generate lots of, variables, results. And we've shown that, from previous work, CFD can correlate with, patient-reported symptoms, like nose scores. These are some of our work we did, and we have very strong correlation. So CFD can help. Again, this is a different project. CFD indeed can help. Let's look at a situation where pre-surgery, the nose score was 65. Post, the same thing. When we look at the CFD results, total resistance reduced, the resistance on the affected, most obstructed side reduced, then the other side, the contralateral side, came down a little bit. Look at flow distribution between the partition left and right side. Pre-surgery, it was very uneven. Post-surgery, there's some, it's still uneven, but there's a lot of improvement. How come this patient is reporting no change? So even when we have the CFD variables and we see some change, the patient's perception might be, is still not enough. So based on that, this project was, okay, how can we combine all the CFD variables we are working with and find a way to predict what the patient will say? Not so much given like reporting results. Can we predict what the patient will say? So that is what this project was about. We started out with just 10 patients. We had pre and post surgery. So this is still very preliminary. And fortunately, we have their nose scores. We did some CFD analysis. We generated lots of results. We settled on 3 variables, the airflow rate on the more obstructed side, which is AS, the airflow partition into that side, and surface area where the heat flux was greater than 50 watts per meter square. We focused on these variables because they had the strongest correlation with patient-reported symptoms. We have the post information also. And what we did was we created a statistical model using the pre and the post. But now the goal was to calculate the change in the score, not just the score itself. So if the patient should report if a patient should report 50 pre and report 5 post, we want to predict the change is 45. Can we predict that change rather than just predicting if it's going to be 50, if it's going to be 45? So we are predicting the change. In this case, our x is just 3 variables. Now we're not looking at just one variable, so we're just looking at 3 variables. We came up with, after a lot of different formulation, we came up with this crazy equation. I know it looks crazy, but that's the reason why, And we did, we looked at the p-values, especially the higher order terms, from x3 square, cube, and the 4th order. When you look at the p-values, even though the values themselves, the coefficients are not very large, but they're significant, so they play significant role, That's what the p-value tells us. We also looked at the p-value of our model itself, and it's for a cutoff of 0.05, it shows that we have significant effect. R square is good. Now, R square tells us that, we have good, relationship. But we all know that the more variables you input, the better the prediction will be. But that is where the R square, the adjusted R square. So the adjusted R square penalizes you for additional variable you put. So looking at our adjusted R square, it's still high enough to feel like, okay, even though we have a lot of variables, those variables are contributing. I'm going to do something crazy. So based on what we did using some patients, and now say, okay, let's try and see if we can predict this particular patient that reported no improvement. Again, this was the correlation we had. We had with the population, we had strong correlation. That is where the patient is. So airflow has some improvement. Pre to post, no change for airflow rate into the most obstructed side. Now for surface area where heat flux was greater than 50 watts per meter square, we saw some improvement, but again, patient, So anyways, with this stuff, we really cannot say much. CFD showing us changes, but that's it. The actual change in their nose score is 0. So, pre 65, post 65, so 0. How did our prediction do? Can anyone guess? Do you think our prediction got to 0? How about 5? How about 10? Anyways, we got 1. So it's not 0, but it's good. I think it's good enough, So why do we need predictive models, Why do we need this stuff? Why am I spending so much time coming up with some crazy equation that can predict change? And this is why we need it. You have a pre-surgery situation. Oftentimes, the surgeon does not have any information about the post. So there's no post information. And you have this surgeon in his mind thinking about, how can I create a post that will look like this, that will maximize their post-nose scores? So that's what the surgeon is thinking. At the same time, the surgeon is thinking about, I have this like gazillion different surgical procedure I could do to optimize my outcome. Which of these is best? So those are what the surgeon is thinking. And I think that's where our model, our predictive model can help. So this is a case study where we have, pre-nose as well as we have CFD results. We now generated 7 different combinations of virtual surgery. That's where your stuff will really be helpful, if we can, because what we did there was just using a very crude 2D method, which is just a pain, So we generated 7 different virtual surgery combinations, even some that are just unreasonable, some that we know that surgeons will never do. Let's see what happens. We try to use the virtual surgery information and the pre to predict what we think the nose change will be. And our goal is to see how is our prediction going to be the same as the actual nose scores. Okay, so we had 7 combinations, right? And this is the airflow rate. So the vertical bar shows us where we feel, based on normative data we have, what should be reasonable unilateral airflow rate that is within the normative range. Unfortunately, we have like 1, 2, 3, 4, 5. We have 6 different choices for airflow. So which one do we choose based on CFD alone? It's kind of hard. So looking at, the partition of flow into that side, we have 1, 2, 3, 4, 5, 6 that look good. Surface area where heat flux is greater than, 50, we had 1, 2, 3, 4. Which of these do we choose? It's kind of hard because CFD gave us results, but now we are not sure which one is good. Let's look at the predictions. So based on the predictions, we see that, our prediction tells us that some combinations are bad. So negative value means this is just terrible. Some combinations are good. Like, if you perform turbinate reduction on the less obstructed side, you have the highest, 84. But let's go back and see what UIT means. If we go back, UIT actually was not within any of the normative range. So even though our prediction is saying this is good, it's not within. So we can say, okay, maybe our prediction look good, but we want to stay within that range. So we can now decide, let's not do UIT because it's just not within that normative range. Let's go to the next one. The next one is septoplasty alone or septoplasty plus UIT. So 65 and 70. If we look at where those two combinations are, they are where in each of these normative ranges, they fell right inside. So the surgeon can feel very comfortable that based on our CFD variables and my predictive model, my choices should be septoplasty alone or septoplasty with inferior turbinate reduction on the contralateral side. So this is how, with our prediction, we've been able to narrow the surgeon's options. Okay, let's see what the actual nose score prediction was. Sorry, the actual nose score was. It's 65. And the procedure that looks very close to what the surgeon did. So this is actual. So from our combination, one of them is very similar to what the surgeon did. And that procedure, it's septoplasty with IT on the less obstructed side. So SEP UIT, which is 70. And I know why it's 70, a little bit higher than 65. But it's still close, So once again, these are my, my good friends, Thank you.